Hi and welcome back to another video of Medic Notes. This video is on tumors of nervous system. They can be classified into primary and secondary tumors. Primary tumors are further divided into glioma and non-glial tumors. Glial tumors are astrocytoma, glioblastoma multiforme, medulloblastoma, ependymoma, and oligodendroglioma. Whereas non-glial tumors are meningioma, acoustic neuroma, and pituitary tumors. Secondary tumors are metastasis from other sites like lung, breast, kidney, and melanoma. Let's look at the glial tumors first. For astrocytoma, peak incidence in early middle age. Vary in malignancy, some being slow-growing and infiltrative. Most malignant astrocytomas are radioresistant and overall survival is usually less than 5 years. In children, the tumor is often well differentiated and cystic, and occurs in the cerebellum. This type is histologically benign, and may often be completely excised with potential cure. Second is glioblastoma multiforme. It is the most malignant brain tumor. Grows rapidly. Occurs between 40 and 60 years old. Rarely removable surgically. Radioresistant, and most patients die within 1 year. Third is medulloblastoma, which is the commonest glioma of childhood. Occurs in first decade of life. Arises in roof of fourth ventricle and infiltrates into cerebellum. May cause obstructive hydrocephalus. Spreads by CSF and may seed on spinal cord. Fourth is ependymoma. Those arising from the choroid plexuses of the ventricles may be totally removable. Those arising from the ventricular walls are difficult to remove. Most are well differentiated. Malignant forms, however, may seed via the subarachnoid space. And lastly, oligodendroglioma. It occurs in the cerebral hemispheres. Slow growing. Usually ill-defined infiltrating neoplasms. Most patients die within 5 years of diagnosis. Next, for non-glial tumors. First is meningioma. Arise from arachnoid cells. Usually occur in females in the 40 to 60 age group. Compress cerebral cortex early in their growth and therefore fits may be an early sign. May cause osteoblastic change in overlying bone, giving rise to exostosis, producing a palpable lump over vault of skull. Most frequent sites are parasagittal region, sphenoidal wing, olfactory groove, and foramen magnum. Usually slow-growing, do not invade brain tissue, but compress it. Small tumors are usually curable by excision. Even with subtotal excision for large tumors, the prognosis is good. Second is acoustic neuroma. Arises from Schwann cells of the nerve sheath of cranial nerve 8 at the internal auditory meatus. As tumor grows, it expands the internal auditory meatus, extending into the cerebellopontine angle, and compressing the pons, cerebellum, and adjacent cranial nerves. May be a feature of von Recklinghausen's disease. Diagnosis should always be considered in patient with unilateral sensorineural deafness with tinnitus. Usually occurs in 30 to 60 age group. Facial weakness with unilateral taste loss is a later manifestation. Corneal reflexes are lost relatively early when trigeminal nerve is stretched by the tumor. Dysphagia, hoarseness, and dysarthria may arise due to involvement of cranial nerves 9, 10, and 11. Unilateral cerebellar signs and features of raised intracranial pressure may occur. That's for primary tumors. Next, for secondary tumors. The brain is a common site for metastasis. Commonest neoplasms metastasizing to CNS are breast, bronchus, kidney, colon, and malignant melanoma. CNS tumors may present clinically in two main ways. Local effects, including cranial nerve palsy, epilepsy, and paraplegia with spinal cord tumor. Or mass effects. Many tumors may present with nonspecific signs of space-occupying lesions without any localizing signs. These symptoms include confusion, drowsiness, headache, and vomiting. Other features may relate to development of hydrocephalus and intracranial herniation. Pituitary tumors. These may cause symptoms because of endocrine capacity, or effects on optic chiasma. Pituitary tumors can be secretory tumors like prolactinoma, or non-secretory tumors. For secretory tumors, many tumors contain a mixture of secretory cells. Presentation is influenced by the hormonal production and size of the tumor. Secretory tumors are usually small. Secretory tumors may result in the following: overproduction of growth hormone. Before fusion of the epiphysis, this will result in gigantism. In adult life, acromegaly results. Hyperprolactinemia. This is characterized by amenorrhea, infertility, galactorrhea, and impotence. And also Cushing's disease. Whereas for non-secretory tumors, they usually grow to a large size and present through local effects. Symptoms and signs depend upon whether tumor is due to endocrine capacity or local pressure effects. Bitemporal hemianopia results from compression of the optic chiasma. Compression of secretory cells by non-secretory tumors may result in hypopituitarism. Symptoms of hypopituitarism include reduced libido, infertility, amenorrhea, myxedema, depression, loss of sex characteristics, hypoadrenalism. And in children, growth arrest may occur. That's all for this video. Thank you.